think this is a great question. A lot of patients come in with complaints on both extremities, and it's not unusual to have problems like carpal tunnel or trigger fingers that occur on both sides. Oftentimes there's a variable degree of severity, so one side is usually worse than the other, and the patients will readily tell you, that my right side really bothers me and the left side only a little bit. I essentially would approach them both similarly in trying to examine both arms separately to try and determine really where the problem lies on each extremity. But in the back of my mind, I'm always looking for a common cause. So in addition to having problems like carpal tunnel syndrome, nerve compression at the wrist, or cubital tunnel syndrome being nerve compression at the elbow, you can have problems at the neck, which can be a sort of a common pathway that would cause symptoms in both extremities at the same time. So it's important to try to differ one from the other. And then the other part is that they're not mutually exclusive, meaning that you can have both occurring at the same time. And that's something we call a double crush, which is also fairly common. So it's important to see these things, and sometimes other testing, such as a nerve conduction test that would be performed by a neurologist, can be very helpful in determining the difference between the two. This is another really interesting question, because the answer to that is no. There's no test out there that is 100% accurate for any given condition. Any test, even an MRI, even a CAT scan or a nerve conduction test, has some degree of fallibility. There's statistical properties called sensitivity and specificity regarding any test, and no test is 100% sensitive or specific, meaning that there can be some patients that have positive results when they don't have the problem, or some patients that do have the problem with a negative result. Although tests such as nerve testing is very accurate in the high 90s percentile, they aren't perfect, and which is why problems like carpal tunnel syndrome is considered to be a clinical diagnosis, meaning that it's really a constellation of symptoms and findings on a physical exam that lead you to reach the diagnosis. And a test such as a nerve test, while very helpful in many instances, is not necessary or required to make the diagnosis. There are other elements out there, such as self-report questionnaires, that have been shown to be equally as accurate in predicting the presence of carpal tunnel syndrome, which do take into account history and physical exam elements. So for me, it's a clinical diagnosis, and I use sort of my physical exam and the patient's history to really determine what needs to be done. A lot of times a nerve test can be very helpful, and it is something that I definitely use in the patients that need it, but not in every case. And also other things like steroid injections can also be useful, which can be a helpful predictor of problems, especially when the nerve conduction testing is either we think it's not right or the results are equivocal. It can be very useful. I think the way I tend to approach this issue with patients is patients that come in certainly with either a diagnosis that's not 100% certain, or patients that will present with either early stage or mild disease can be treated non-surgically. And these tend to vary in treatments from splinting, such as splinting at night, in those patients that have symptoms where they'll be woken at night with pins and needles or burning pains. Other potential treatments are some therapy, such as stretching or gliding exercises, have been shown to be a little bit helpful. In addition, cortisone injections can be a very helpful non-surgical treatment. They're generally not a permanent solution, but they can be a very good screening tool for patients that will ultimately go on to respond very well with surgery. And it definitely can be my preferred approach in someone who the diagnosis may be a little bit unsure. So oftentimes I'll give an injection and see how the patients respond, and then you can buy yourself sometimes 6 months or even longer of symptom-free, where you can, until the symptoms come back, and then we start talking more seriously about surgery. But certainly in the patients that present at a later stage with more advanced disease that may have wasting of the muscles in the hand or weakness, those are the patients where I really strongly do tend to recommend intervening with surgery earlier to prevent any worsening of the problem. So I think trust your surgeon, trust your physical exam, and you'll arrive at the right answer.